Very late good evening to all my dear members who have joined today. A very interesting subject, close to my heart also, and close to the heart of our past president of All India Ophthalmological Society, Dr. Natarajan, who had requested me that during my tenure, we should have diabetic screening and awareness program throughout the year. And that is how today's first program is there. The motto today that we have is to have pan Maharashtra screening of all the diabetics. General ophthalmologists also should be able to do. And today's webinar is basically covering on the types of retinopathy and how to go about it with a simple 20D lens and your mobile camera, how to take the fundus pictures. So you yourself can read it. If you are not aware, you can send it to your VR person and get it done. And that is why all of us today we are here. Dr. Natarajan was supposed to start, but because of some personal emergency, we have an equally good speaker with us, our own Vice President of Maharashtra Ophthalmological Society, Dr. Santosh Agarwal, who is going to give us an overview of the types of diabetic retinopathy also, and how an ophthalmologist and how Dr. Natarajan has his dream of covering pan India and also pan Maharashtra. He has sent the PPT to Dr. Santosh Agarwal, who is going to brief us on this topic. So I'll just introduce our own Dr. Santosh Agarwal, who is the Vice President of the Maharashtra Ophthalmological Society. He has done his MS and he was a gold medalist. He is a past alumni of Shankara Netralaya, where he was the best outgoing fellow. He has also done a lot of research and new innovative technique, where he has won for the best research and for the best innovative technique at the Nanded 2004, 2013, Pune 2013, Moscow 2018, at the AIOS 2018, at the POS at 2020, and at the AIOS 2020. For the following research also, the Suresh Limay and the Best Research Award by the Maharashtra Ophthalmological Society in 2018, and Best Video Awards twice by MOS and the AIOS. An innovative visco chopper for automated visco delivery, a boon for complicated phaco, and another one, an innovative, simple, and a novel AC paracentesis device for safe intravitreal injection. A lot of extracurricular activities he has done, and he has earned national awards, Lifetime Health Achievement Award in 2007, International Healthcare Excellence Award again in 2007, and the Agra Yuva Acharya awarded by the Agarwal Yuva Manch, and the Best Achiever Award by the Lions Club, and the Best Outgoing Vitreoretinal Fellow at the Shankar Netralaya. So we have a very esteemed speaker, our own high host faculty, our own second Vice President, Dr. Santosh Agarwal, who practices in Aurangabad, is a roaring practitioner, mainly does the VR work, and he is going to go about the PPT sent by Dr. Natarajan. Dr. Santosh Agarwal, over to you.
So at the outset, I thank MOS, Dr. Taswala and Dr. Natarajan for giving me the unique opportunity to present this very important talk, how to screen and how to curb the blindness due to diabetic. That is Diabetic Blind Free Maharashtra by Dr. Professor S. Natarajan. The magnitude of diabetic retinopathy is alarmingly increasing. According to the International Diabetes Federation India, 77 million diabetics are there. In fact, by 2030, it would be 101 million, and by 2045, it would be around 135 million. The diabetic retinopathy as well as maculopathy, the magnitude of problem is increasing, and it ultimately makes the patient blind. We recommend primary checkup at the time of diagnosis of diabetes. So prevention is better than cure.
As President of All India Ophthalmic Society, I would like to thank the International Advertising Agency for starting this competition for making a campaign on preventing diabetic blindness. And I also like to thank Allergan for the generous support to make this public initiative movie to create awareness on diabetic retinopathy and how to prevent diabetic blindness.
The world will forgive you, but will you forgive yourself? Diabetic blindness is preventable. If you're diabetic, you need a retinal checkup to prevent vision loss.
So the dream, my dream, means it's Dr. Natarajan's dream is eye care should reach every village in India to eliminate preventable blindness. Use of smartphone to take good retina photographs.
And now I have to bow down to Saint Thiruvalluvar. Is the starting word for the English, and the same way the starting of the universe is God. And the vision 4 is stop blindness, nationwide diabetic retinopathy screening called the Jot Se Jot Jala. We did the lamp lighting, and again our late Babarajan coined this for Dr. NSD Raju and Dr. Subhuti. Diabetes invariably affects both eyes. Test your eyes soon, and that's the acronym. And then Dr. Radhika made this acronym, screening through teleophthalmology for prevention of diabetic blindness, called Stop Blindness. And I made I want every ophthalmologist to have a slogan, and I'm glad I think our industry will support making posters in all over. And are you diabetic? Are you hypertensive? Do you know you may go blind? And I'm glad that Dr. Lalit Verma started for the ophthalmologist for the eye checkup to be done. And thanks to Zeiss and Allergan for that. 73 million Indians are having diabetes, 7.3 crore, and we only have 22,000 ophthalmologists. How are we going to match it? So we have a task force. Thanks to Dr. Ajit Babu and the Governing Council for approving, and we have the Dr. Lalit Verma, Dr. Partha, and then all the staff members, and thanks to Rajiv Raman, who organized it in Chennai on January 20th. I also given an appeal to Mr. Radu Data. We have 2 members of parliament, one Dr. Vikas Mahatme, who's a Padma Shri, and Brigadier Dr. Watts, who was the commandant of AFMC Pune, now an MP from Haryana, and whom I told them you should work for ophthalmology too. We also met the then Health Minister of Health in Maharashtra. So I want to introduce this portable fundus cameras. I don't have any financial interest. It can be mounted on a suitable bike, and I wanted to show that it's a 30-second movie. He's a 10th standard failed boy. I call him the hero of our foundation. He just takes the camera in the backpack, and they can take a fantastic photograph of retina and send it to the either reading center.
With the ever-increasing number of diabetics and the limited number of ophthalmologists available in India, it is difficult to screen all diabetics, especially those living in remote locations. The fundus cameras currently used in taking fundus images are expensive and not non-portable. The solution to these problems is to train people to take fundus images using a portable camera and to use artificial intelligence to detect referable cases, so that need for ophthalmic surgeons for screening is minimized and they can utilize their time to treat those who are actually in need. This way, we can get eye care to reach every village in India. Now, role of artificial intelligence, it is still lacking in our country, but it has good future AI is likely to be best or worst thing to happen to humanity. It is up to us which one it's going to be. We need more working hands and we have to use minimally trained staff already available. We arm them with artificial intelligence to bridge this gap. Intelligence is the capacity to analyze, to think, make a decision, and categorize. Artificial intelligence involves training the computer to develop this capacity. The computer is trained to accept retina pictures properly taken by the trained semi-skilled worker, compare it with thousands of previously provided DR pictures, and based on that, notify the staff which patient needs to be referred to an ophthalmologist. So the work is taken by computer instead of a optometrist. It is labeled as referable diabetic retinopathy. So role of the AI system, integration of retinal photography and artificial intelligence, AI-based grading and diagnosis system for referable diabetic retinopathy patients. It performs the following procedure fully automatically. It identifies fundus pictures, it classifies it, and it also gives the grading and severity of the disease based on deep learning technology. What are the advantages of AI? General practitioners, primary care physicians, and caregivers can easily diagnose diabetic retinopathy using this simple and affordable innovation. The potential to make a huge impact both on the disease social and economic dimensions. Advanced image processing capabilities allow clinicians to work even with low resolution fundus images. It is relatively lower cost than manual methods. Accuracy is about 90% according to initial pilot study. Highly scalable process with quick response time. Solution is extensible. Emerging healthcare technologies focus on reducing unnecessary visits to medical specialists, minimizing the overall cost of treatment, and optimizing the number of patients seen by each doctor. What are the disadvantages of this technique? A negative AI-based finding may give the patients a false sense of security about the totality of their ocular status. Emerging evidence from the Joslin Diabetic Center shows that DR lesions in the peripheral retina are highly predictive of which patients will develop proliferative diabetic retinopathy, the blinding form of the disease. Plan of the action for screening is, first is screening, then you have to diagnose it by the trained ophthalmologist, and then you have to treat by the VR person. What is the process or flow chart for the nationwide screening? It is laid down here, very well depicted in a flow chart. That is the pre-camp awareness, which is very much required among the people. Assembly of diabetic patient at one location or one center, and capturing of images and uploading on the communication media, and then diagnosis by the ophthalmologist, and again the treatment by the VR person. Now it is the simple classification of diabetic retinopathy, which we all know is the basic classification by ETDRS. That is, one is non-proliferative diabetic retinopathy. It can be mild, moderate, or severe. Microaneurysms, dot and blot hemorrhages, and hard exudates are seen in non-proliferative diabetic retinopathy. In pre-proliferative diabetic retinopathy, you see CWS, erythemas, venous dilatation or venous changes, and dark blot hemorrhages, pre-retinal hemorrhages. In proliferative diabetic retinopathy, mostly you see neovascularization of the retina, that is elsewhere, or on the optic disc, it is called NVD, or on the iris, that is called as rubeosis iris or glaucoma. You can see maculopathy at any stage of the retinopathy. It is a clinically significant macular edema, ischemic maculopathy, and diffuse maculopathy. Now this is the fundus camera of Remedio, which can be mounted on suitable bike for transporting for screening purpose, can be mounted on any table. It is chargeable. It is very handy. These are the pictures how to take the fundus images in camps. There is one small video.
Authority of Ophthalmic Society. I would like to thank the International Advertising Agency for starting this competition for.
You can move forward, Santosh. It is already shown. Same thing.
Also like to thank Allergan for the generous support.
So these are the different presentation by Dr. Natarajan. The community-based screening mostly has done screening camps in Dharavi, in Mumbai. These are the photographs which shows his extensive work academically as well as in camps. Sensitivity and specificity of AI in detecting referable diabetic retinopathy was 100% and 88.4% respectively, compared to ophthalmologist grading. The sensitivity and specificity of the offline AI in detecting any diabetic retinopathy was 85% and 92% respectively, compared to ophthalmologist grading. So it is comparable.
Right.
Early detection and treatment after screening can reduce the prevalence of diabetic retinopathy even in remote areas. That is very much required. Reduction in the economic burden among poor and illiterate people. Opportunity for semi-skilled workers. It will help to improve overall health of the population. ABCD, anybody can screen diabetic retinopathy. As Dr. Natarajan already has shown in the video, a non-matric person also can do this. Stop Blindness AIS initiative. AIS has put forth many guidelines for screening through teleophthalmology for prevention of diabetic blindness. Jyot se Jyot Jalao. So these are the different camps which were held by Dr. Natarajan. This is Dr. APJ Abdul Kalam, Honorable ex-President of India. Dr. Natarajan has good relation with him. He inaugurated many camps. Now, important points to remember about screening is trained and employed youth of India, even with minimal education and no experience in fundus photography, to reach out to save vision of millions, independent of electricity and internet supply. Better chair time offered to referred patient cases. Timely treatment is required to prevent the blindness. And join hands for the monumental revolution, fight against blindness from diabetes. We can make India free of burden of diabetic blindness, and teleophthalmology can show the way. Eye care can reach every village via teleophthalmology and artificial intelligence. So these are the different staff which helps Dr. Natarajan in his dream come true. Anyone who converts a challenge into an opportunity through innovation creates wealth. He or she indeed is a leader. Are you? Dr. APJ Abdul Kalam. So this is the presentation given by Dr. Natarajan to me. It is very extensive. He is doing tremendous work. I congratulate him, and we will definitely get guidance from him in carrying out the screening camps in Pan Maharashtra. Thank you very much.
Thanks, Santosh. Wonderful presentation. You have taken over from Dr. Natarajan, and as if Dr. Natarajan was doing it, you did a very great job. Now, as you see, the dream of Dr. Natarajan is ABCD. Anybody can do it. So that is one technique of Remedio. Of course, the Remedio camera cost, and usually only the VR surgeons are the people who invest in that. So now that is why we have come up with another alternative and a still easier technique, where the general ophthalmologist can also do this and screen all the diabetics. We have to have a tie-up with the diabetologist in your area and also with a VR surgeon. So the moment you capture the new technique, which we have another faculty, our in-house faculty, a young ophthalmologist who has got a very innovative mind. Before that, I would like to just welcome our star faculty today, Dr. Mohan Rajan. He is the president of the Tamil Nadu Ophthalmic Association, a good friend of mine, an alumni of Shankar Netralay, having a roaring practice and a big name in down south in Tamil Nadu, with a clientele of Dr. Mr. Rajnikant. He is the doctor, the way we have Himanshu Mehta for Amitabh, he is the doctor of Mr. Rajnikant. So we have a star faculty to be with us. There is another speaker, our own in-house faculty. Welcome, Dr. Mohan Rajan sir, boss.
Thank you very much.
We did fellowship together at Shankar Netralay, and that is how, and he is a very nice and a very vocal speaker. His skills of communications. We just had a recent webinar on communication skills. We have another committee. I have about 21 committees. One of the committees is regarding public speaking and personality development. And Dr. Natarajan, Dr. Mohan Rajan has excellent communicative skills and with a tinge of humor. It was really enjoyed. There were 500 people who had joined that day, and it was a fantastic webinar. So we again have him for his views on, because they are doing a fantastic job in Tamil Nadu regarding screening of diabetics in Tamil Nadu, and that's why I wanted him here to share his views. So before that, we have our own in-house faculty, Dr. Anuj Soni, a young dynamic ophthalmologist who is practicing in Mumbai. He has got a special interest in retina, and he is a common face in buffets of national and international conferences. He's a pioneer in mobile fundoscopy, and that is why he's here. He loves teaching and runs a YouTube channel, Clinical Peanuts in Ophthalmology, with subscribers all over the world. Apart from ophthalmology, he loves making videos and cars. So we have Anuj, who is going to give us an insight of the new simple technique of just having a mobile camera and a 20D lens and capture fundus, beautiful fundus pictures. We'll have a small live demo also from him. First, a small PPT PowerPoint presentation from Dr. Anuj Soni. We welcome you to this forum. Over to you, Dr. Anuj.
Good evening, sir, and thank you for the opportunity. Thank you, Mos, and thank you, Taswala, sir, for this opportunity. So I'll be sharing some clinical peanuts on this topic of how to use mobile for fundus imaging. So now if we search for fundus camera for screening, so we have a lot of options, and they range from all sorts of properties, from wide field to true color, and from all makes, and could be Chinese, Indian, or German. But what is common in all of these is you need to buy them. There's none free. As they say, there is no free lunch. So the coming to this, as we say, peanuts generally we get for free. So I would like to show you a small pocket fundoscope, and I would request everyone to check their pockets, and they will find one that there is one fundoscope there in their pockets. And most of us know how to use this device, but not in the true sense. So I will just try to show how to use it in ophthalmology as well, because other uses everyone else know about it. So it is just simple. We just need to have our lenses, whichever color and make which we like. And the other requirement is we need to have a mobile phone, little smarter than these, and with a flash and a video camera. And the third prerequisite is we need a dilated pupil. So if we have all this, then that is it. Our fundus camera is ready, and it is just as simple. So we have a patient in OPD, and you just put the lens in front, and eureka, your fundus camera is ready. I hope the images are seen, and this is a image. You can see a pale retina with maybe a cherry red spot in the center. So looks like a central retinal artery occlusion. And so now coming to today's topic of diabetic retinopathy. Now in diabetic retinopathy, as sir showed us the classification, if we see this fundus, maybe we can see one microaneurysm here. And if we have any doubt, we can just take this video and share it to any of our colleagues. And we know that this doesn't need any referral, and we can just observe or maybe do some systemic investigation. So this just works simply. I'll show some more videos of fundus images. So it will be more of a video essay. So this is little more severe, I would say. You can see many dot blot hemorrhages, and though the macula fovea looks fine, no macular edema. So some cases like this, where asteroid hylosis, you can see some hemorrhages in the background, but better a referral if FFA is needed, because that can be a better imaging. And now you can see angry looking florid neovascularization in the fundus with vitreous hemorrhage. So if we have any doubt whether what is to be done, we can just take the video. And again, you can see proliferation from the disc. The media is little hazy because of vitreous hemorrhage, but you can see a nice proliferation from the disc. And in cases we have any doubt that what is to be done, so this video can be shared, and this video can be shared even live, like how we do a video chat with someone. So that is how this works. Now coming to our classical boat-shaped hemorrhage, we can see a nice hemorrhage, and so maybe a laser would be needed in such case. And so we should avoid trying to take fundus picture in such cases where there is obvious vitreous hemorrhage, because it will be difficult and will not work. But in other cases where we have doubt, like this is nothing, just a normal fundus. Now these, sometimes we see these black marks and we are not sure whether this is laser marks or choroidal scars. To me, these look like lightning burns because they're too dark for laser, but these are not mine. And so you can see this traction from the disc, and you just show the video to the retina colleague. And these are the cases where type 1 diabetic cases where there is severe proliferation and pre-retinal hemorrhage, and you can see fibrovascular proliferation as well. And here, this case, you can see a fresh bleed from the inferior arcade, and such videos help not only for documentation, they also help in educating the patient, because if you tell him and if you show him, it really makes a difference, because blood is blood. Everyone knows that there is blood inside the retina, and these are scary also. So it really helps for a patient to understand the magnitude of the problem. And if we see for retinal findings, you can see this hemorrhage in the inferior arcade, and as we go superiorly, we can see some fibrous proliferation. And there is little, if we go nasally, we can see neovascularization. I hope it is seen. And these videos are recorded at the best quality, because nowadays mobiles are recorded at 4K resolution. So there is no better view than this. Even if you buy a camera which is 10 times more expensive, you will not get these pictures from it. So now this, you see a pre-retinal hemorrhage, and you don't know whether patient may need surgery or it may, so you just share the images and you can counsel the patient accordingly, and treatment can be given in time. Again, a case where you can see traction. So these are taken directly from mobile and just the 20D, and there is no device or anything in between. So this is just pure ophthalmology, pure medicine. There is no financial disclosure to be made in these images. Now you can see hard exudates at macula. You, sir, was talking about clinically significant macular edema. So these are the cases where injection may be needed. And here you see fresh bleed, but if you see the retina in the background, it looks normal. So once you show this video, you know that you can observe it for some time. Maybe systemic investigation can be done to find out the cause, whether it is diabetic or PVD induced. And sometimes you don't know what it is. There is patient complaints of floaters, and there is some vitreous condensation. So, and again, a case where you can see bleed near the disc. And if you see closely at the disc, at the superior border, the artery will see, you can see it pulsating as I put a little pressure on the eyeball. So if you focus on the artery near the disc, it will pulsate in a second. Yeah, so you can see the pulsation as well. And so this is just, so these cases, bilateral pathology doesn't look like classical CRVO, doesn't fit in diabetic retinopathy. You know, they need to be investigated systemically. They need treatment, even ophthalmic. And some cases you are confused whether they are exudates even at the macula, at the disc, but then you are confirmed that, okay, these are drusen and maybe myelinated nerve fiber, so they don't need referral as urgently as you may think. And sometimes patient doesn't give history and you just see white spots, you don't know what they are, so, and you have never seen fresh retinal burns before, so you know that these are just a PRP. So this case of macular edema, you just see the fundus and you see something white floating. Patient doesn't give any history, but you can check that, okay, these are IVTA particles floating. Again, you feel that there is a foreign body inside the eye, but this is Ozodec. If you compare the right and the left image, the left is an older image, hence the implant is much smaller. And sometimes we are used to seeing the long implants, and with the small implants, we get confused what it is. And again, a case of proliferative diabetic retinopathy with vitreous hemorrhage inside. So these images, they act as a record, and they also help as a teaching module, and also help in spreading awareness. So, and they are simple, they are easy, and they don't take much of your time as well. Now, again, a case where you can see this is a traumatic vitreous hemorrhage with a subretinal hemorrhage. So not related to diabetic awareness, but it is a small child and you don't know what to do. So you just take a photo and maybe you are seeing it in the night emergency and you just send whether it needs an urgent referral to some institute or medical college, or you can just observe it medically. So this just helps. And again, here you have a doubt whether there is macular edema, because in the other eye there is macular edema and here this is drusen. Well, these images are of different patient, but this just helps. You just take this video and share it with your colleague and they just tell you that the one patient needs intervention, the other can maybe observe. So diabetic retinopathy is just one spectrum. We know that branch retinal vein occlusion, even vein occlusion, are very much part of diabetes spectrum of retinal disease. And you see this patient and you see a macular vein occlusion. We need to remember that these images are inverted. Same thing as we have in our indirect. So this would be a superior. And so you just can take images, and you can take images of the periphery as well. Currently, I don't have images to show of periphery. Vein occlusion, and not just branch retinal vein occlusion, even central retinal vein occlusion can be a part of diabetic disorder. And so you see this patient, multiple hemorrhages. You focus on the macula, you see macular edema. And so whether you should investigate, what to investigate, and how to counsel. And patient lives far off, or there is no one to treat, so you can just check with your retinal colleague. And the newer spectrum of diabetic disease in these COVID times is you have to do ICU calls and nursing home. So you cannot take your fundus camera and you don't know what the patient is having. So you can see a pale retina. Please excuse the broken 20D. Nobody was ready to spare it for a COVID patient. So we had to manage with that. But you can see that retina is pale, and this is case of mucormycosis seen in a nursing home. So even if you don't need any investigation, nor do you need to burden the patient with any expenditure just for imaging purpose. So this is where it helps, and it is not just for imaging. It is also for documenting. So you have treated an eye, and you have given injection, and you just follow up with images, and you see how the morphology is changing, how the tortuosity have reduced, the hemorrhages have reduced, and so you can show it to patient. You can use it for research purpose, and if you get an opportunity at Mos, you can put these images again and for your presentation. So the mobile fundoscopy does help in all our aspects, and we have a lot of options. If you don't want to use just mobile, you can buy some adapters, and there are a lot of them available. This is one particular type which is available, no financial interest. So if you search online, they range from 20,000 and go upwards. But the problem with these is that you cannot store them in, and when you need, you will not find them because you will not use. So in your OPD, you end up searching when the patient comes, and you don't know where it is. The staff doesn't understand what you're talking about, and finally, when you find them, so then you cannot put them in your pocket. You cannot carry with them around, and you have to attach the 20D again. So either you have to spare two 20Ds or a spare mobile. Otherwise, for every patient, you have to first check with your 20D, then attach this to the adapter. And then with these larger mobiles, it is difficult to fit. And we just do a disclaimer that we did not damage our 20D in this video, but this actually happens. And so coming to the optics of mobile fundoscopy, actually, I don't know the optics. It is just like indirect ophthalmoscopy. So sorry to burst the bubble. I don't know the optics. It's just turn the flash on and use the 20D. And this is how it is. This is a demonstration. I'll just show it to you. So basically what you do is in your mobile, you just turn your flash mode on. And once the flash is on, you have a dilated patient sitting in front of you. Hold your 20D, ask the patient to focus. And you have to hold the lens very still. So you can rest it on the brow. And once you have done that, it is just, you can retract the eyelids, or you can ask the assistant to hold the lids, and you can just start recording with the flash mode on. And that's it. There is nothing. You just need to get the image in the 20D, and simple, the way you do your indirect ophthalmoscopy, ask the patient to look left, right, and it is done. Now, thing what happens is sometimes we need to focus little high mag, like for macula or optic disc. So in those cases, the only thing is we need to decrease the distance of the mobile from the lens, and bring the lens as far away from the eye as possible. So you can see I am bringing my lens as close to the eye. And if you see on the right, you'll see what is actually happening in the mobile. This is the view which we get from mobile. So there is a magnified image which we are getting. So if we want to increase the field, we just have to do reverse. That is, we just go back and increase the distance between the mobile and the disc. So further away we see from the mobile, the more view we will get, field of view. And if we want magnified, then we have to bring the mobile as close to the 20D as possible, and bring the 20D as far away from the eye as possible. So this is just it just takes what you say, a little bit adjusting in time, but we do get it. We've been trained in direct ophthalmoscopy, indirect ophthalmoscopy, and we have not learned it in a day. Just the trick is that we need to start practicing on normal patients instead of pathologies. You just take a normal fundus, take a video, and that's it. So we do it routinely, and we just get it into practice, because everything is there with us. There is nothing that it has to be a special setup or anything. If you have a dilated patient, you can just start. So now coming to what are the don'ts? So simple, if you have a patient who has nystagmus or uncooperative, who's not going to keep his eye open, maybe mobile fundoscopy is not for him. Other thing would be cases of media opacity. You have a patient with dense cataract and you're trying to take a fundus photo with a mobile. It might be a little difficult because the glare will be too much. And other patients would be like who are very symptomatic. So such patients will not cooperate for mobile fundoscopy. And other than that, any patient who is dilating and has clear media, definitely you can go for mobile fundoscopy. And this you can go really up to the aura. You can demonstrate indented videos, but you just need an assistant. And if you want, you can even ask the patient to lie down if you are comfortable and ask your assistant to retract the lids. And so I'll just conclude this talk. And if you want to watch some videos, maybe you can log into the YouTube channel and you may find some more videos. And I think that would be from my end.
Thanks a lot, Anuj. Fantastic. I think it is the cheapest way where we can do a lot of things which even the best higher-end cameras and the machines can't do. So very nice, innovative technique. I liked it. Only thing I just wanted to ask you is two things. Any fundus, any mobile camera will do, or you require any specific requirement? That is one. Second, do you put the video on, or it is only the on the picture mode that you do it? And all the cameras don't have the flash on when the camera is on. It doesn't allow it. Allows only flash when the light conditions are bad. So what are the suggestions for this?
So I would say single camera is always better. Single lens camera would be better than using dual lens because they have a better focus. So, but all cameras can do. There is no this. And other thing regarding this turning the flashlight on is you just have to put your finger on the sensor of the camera when you turn the video on. So it will turn the flash on if it is on auto mode. Okay. So you just go to your video and you just put a finger behind your lens and you turn the video on. So flash will automatically become on, because new cameras, you cannot put the flash on unless, so there is an auto mode. So you just put your hand and the flash will work. And other than that, there is, you can use any phone, even Android phones or iPhone, any phone will do. And it is on video mode, because you don't know when you will get the best picture, because the patient will be moving. And sometimes I feel the videos are much more dynamic, and you can, for explaining the patient,
better.
It is a better way.
Yeah. Second is the dominant hand you hold the camera and the non-dominant hand you hold the lens.
So personally, I like to hold on the camera on the non-dominant hand, because it is easier for me to retract the lids and hold the lens. But it is totally each one's
individually
custom, because how we do indirect ophthalmoscopy, if we like to hold with the left hand, then
it's better to hold with the right hand, because you need that stability of the 20 diopter lens.
Correct.
Otherwise, you will keep losing the image. That is see, what he is doing is nothing but video indirect ophthalmoscopy.
Absolutely.
Same principle is there.
Absolutely.
Instead of the ophthalmoscope, video indirect ophthalmoscope, he is using a camera. That is the cell phone camera, smartphone camera. So that is exactly what he's doing. So you need to make sure that the image is retained. For you to retain that image, you need your dominant hand and retract the lid so that you can have the lens stable. The 20 diopter lens has to be stable. Otherwise, the image will keep coming and going, keep coming and going. We have seen that even when we started practicing indirect ophthalmoscopy. So we need to retain that image for you to get a better video. Am I right, Anuj?
Yes, sir. Yes, sir.
I was very impressed with the fantastic.
We need to use
Dr. Anuj.
Yes,
very
sir.
well presentation. Your
Thank you,
device
sir.
is very inexpensive and very easy to use. But is it possible to be used by optometrist or the paramedical staff at remote place?
Actually, today only for this presentation, my optometrist showed that he has seen some patient in his own village somewhere, and he has shown me the fundus. So definitely it is possible. But yes, there is a bit of learning curve. But it is very much possible once they know, because most of them have not seen how people do indirect ophthalmoscopy, so they don't get a hang. But as sir was saying, once you know that your right hand has to be stable or your dominant has, so that is very much possible. And because you see what you are imaging, so there is you actually pick up things. So
Yeah.
Anuj, there is one more thing. Majority of the camera phones, when you put the video on, the flash doesn't come. You said one idea is that. Second is there are certain apps which you have allow you to have the video in the video with seeing the flash on. I think one
yes,
is footage. When I spoke to Dr. Bhatti, one of the pioneers in ophthalmic photography and videos, he said there is a footage camera. So for the benefit of the ophthalmologists, if they are not comfortable covering the sensor, they can download the footage app, camera app, and that also allows you in the video mode the flash on. And of course, as Dr. Mohan Rajan rightly said, if you can steady the hand properly, then only you can take the image. The
Yeah.
camera is so comfortable, it's not a huge size. It can easily fit in your finger, and you have the video mode on already, and you just have to focus it with the other hand. So it is going to be very easy. It's not a long learning curve. Everybody can do it. I'd like to have comments of our wildcard entry, or the most renowned retinal surgeon that we have in Bombay, Dr. Vatsalbhai Parikh.
Yes.
Over to you, Dr. Vatsalbhai. Your comments, please, before
Anuj,
we
I
start
think
the
this is
interactive discussion.
Anuj. I never thought it was so simple. You made it so simple to do it, and I feel that probably everyone may not have slit lamp, but everyone can afford to have 20D lens, and everyone,
Yes,
even today, a sweeper will have a mobile phone. So I think
yes,
what you have shown is, I think, not only though we have the most expensive gadgets in our clinic, but we should also learn, because there are certain things which an indirect which a fundus camera or indirect ophthalmoscopy would delineate better than any fundus camera, especially if you do not have non-mydriatic camera, if you do not have wide angle camera. Today we have ultra wide angle camera, so there is no problem to capture anything. But suppose you want to capture retinal tear in equatorial region or something, then routine fundus camera won't capture, whereas your camera would be definitely very good to capture. I
yes.
think all ophthalmologists should learn it, and maybe I'll come once to see you how you're doing, because you made it so simple that it looks that I can start it from tomorrow. But
I'll come there, sir.
Sir, he has
my
also mentioned an Ullman indirect app which keeps the camera, I mean the flash on, right, na, Anuj?
Yes, sir. Yes, sir.
Yeah.
So we can adjust the exposure with this app. So earlier when I started, I was using this app, but now the mobile cameras are, they can do the work very well. So the
So,
only thing I suggest is to take videos, and then we can take snapshots, images
Right.
for a small video.
that can be done.
Yeah, Kamini. Anuj,
That
I would
can
like
be
to
done.
just make two comments, Anuj. One is you're absolutely, as Vatsal rightly said, and Jignesh also, you fantastic presentation, very doable, very practical,
Yes.
very feasible. The only two drawbacks as far as the screening in the periphery is concerned is that you need a dilated pupil for this, number one.
Yes, yes.
Number two is you need some training in indirect ophthalmoscopy.
Little
Okay.
bit.
And surprisingly, we find that many ophthalmologists themselves are not trained in indirect ophthalmoscopy. Many of them are still doing direct ophthalmoscopy only. You'll be surprised to know the numbers. I do not know
Absolutely.
exactly the numbers, but it is increasing. It is much. What I'm telling you is it was, if you take about 20 years back when we were doing fellowship, 20, 30 years back, Jignesh, hardly
Yeah.
anybody did indirect ophthalmoscopy at that time.
Correct, correct.
You remember,
Absolutely.
all the
Yeah, yeah.
ophthalmologists, they used to refer all the patients to Dr. Badrinath and Shankar Netralaya, and they were all doing direct ophthalmoscopy, including my father, who was practicing at that time. I'm telling you, the number has definitely come
Increase.
down. The people are using only direct ophthalmoscopy, but
Correct,
still there is a group of people who know only direct ophthalmoscopy. They don't do indirect, or they do slit lamp 90 diopter or
Right.
70 diopter. They're more comfortable with that. That's why the Aravind model, no, they do the Aravind, the 90 diopter, but the optometrist, the 70 diopter in the vision centers, and that also requires a dilated pupil again. You can't do it.
But the
So,
magnification and the image capture is not so good with 90D and 70 the way we have it 20D.
still you can good. We can get very good pictures.
Okay.
With a very good pictures, very doable. I have done it myself. With I used to do it with the Nikon camera before, but nowadays all the smartphone cameras are available, so which is very doable. It's not a problem at all. Vision centers, they can do it, and the optometrists can also do it. And as Anuj rightly said, even the optometrists they can do the the indirect ophthalmoscope is not as easy as you think. The slit lamp is easier because you're able to do it because you have that what do you call that stability in your hand. Okay, but the indirect ophthalmoscope, the problem is that the image will keep on moving, you will very difficult to retain the image.
Yes.
Yeah, very difficult to retain the image. I do not know, but this is a practical learning curve. I'm talking about see how to penetrate this technology to each and everybody. That is the main idea of this objective
Absolutely.
of this webinar.
Absolutely.
Am I right?
Yeah.
So we need to do that. We need to do that. How to develop? So you need to make sure that to make this indirect ophthalmoscopy a little more easier for them to learn. Because
What we
Can
can
I
do
say
is,
something, Vignesh?
Mohan, I have in mind, instead of having a finger to steady this, you have a small gadget which just holds it
He has
here.
already
So
shown
your
that.
hand is steady.
He has already shown that.
That's shown. He has shown that. No.
Correct. So,
Mohan, can I say something?
Yes.
bolo sir, bolo.
Yeah, see, I think what you are saying, Mohan, is partly true. Partly true for the simple reason that this will not require high skills, to master it. And
Right.
once you have got a good picture, then if you are doing 90D or 78 diopter examination, then you know that this is superior, inferior, lateral, or medial. I think today, if I have to learn computer, it's maybe difficult, but for a 20-year-old guy, it may be easier. So I don't really feel the way we learnt indirect ophthalmoscopy, we had to see those small mirror attached to the side, where we had to struggle where to look for, through the side mirror. Whereas those things are all totally avoided here. And once you record, you will gradually learn it. So in my opinion, this would be the easiest way to learn. Because you can show your image to somebody else and he will say, this is this is that,
Correct. The technique itself, we don't have the headband on. We just have a camera in a hand, and everybody is so used to take videos and this. So only thing is your left hand, the dominant hand has to be a little steady. So it won't be a problem according to me. A slight
And
learning
pupil
curve,
is-
of course, but it can be easily picked up.
It would not be, if the mental resistance has gone, it would be very easy to pick up if you learn the right technique.
Correct. And
That is what I
interpretation
feel.
can be done by a VR surgeon. You don't have to interpret north, south, up and down. So that will be done by a VR surgeon. He has to capture the images properly. And that with a little learning, I think what Dr. Vatsalbhai has said, it is very easy. I don't doubt, because the moment he told me, I started doing it. Though I have done my VR, but I don't practice VR, and I could immediately do it. And that is how I got an idea. Instead of a Remedio camera, why not have this? Everybody has got a mobile phone. And the app, what he said to the Ullman, indirect, is very nice. The moment you put it on, the flash is on, and you can do it very, very, very easily. So it doesn't look to be that difficult the way it was.
So maybe for 70-80% of cases, this will do at minimal cost.
Yeah, and only about 20-30 will require this Remedio camera who are not able to do it. And of course, we can start a training institute where we can send people like Anuj can be there, Vatsalbhai can be there. Other VR surgeons can definitely train some few people in about 15 days to 3 weeks. And then we can spread it out all over Maharashtra. Those ophthalmologists who are ready to learn and help us.
Only problem is we have to do Mydriatic fundus imaging.
Yeah,
That is the only minus point. Yeah.
And
Even
Remedio
non-Mydriatic
has
cannot be done.
that IR camera, that is infrared camera. So we don't have to dilate the pupil in that. That is the advantage of Remedio. And in periphery, I think we can't allow optometrists to dilate each and every patient. That is the concern. We have that concern.
Santosh bhai, today's this thing is the most periphery of the ophthalmologist can definitely dilate in his clinic, and he starts learning this over a period of a month and a half. I think this technique should pick up very nicely. We need to make it aware to every. That is why this today's webinar is there. Now, I think we have a very nice interactive session with Dr. Santosh Agarwal is going to moderate the question answer sessions with Dr. Mohan Rajan and of course Dr. Vatsal bhai. So, and of course Anuj also, you can ask all these questions and make it more interesting. Let's have the question answer session. Santosh, over to you.
Yeah, thank you, Dr. Taswala. We know that diabetes is increasing. Our India is now becoming the capital of diabetic country now. So I want to know from Dr. Vatsal Parikh as well as Dr. Mohan, how they are doing screening at their own setup, how they go about for diabetic screening. In Tamil Nadu mainly, I want to know from Dr. Mohan Rajan, how screening is done.
In Tamil Nadu, we have basically in the hospitals, we are doing the screening with the fundus camera, but we have started a new concept called along with the rotary. Are you able to hear me?
Yes,
we can hear you very much.
Hello?
Yeah, go ahead.
Hello?
Go ahead, Mohan. We are
Yes,
hearing you.
Mohan. I think he has lost connection.
He has lost connection. Vatsal bhai,
Hello?
Vatsal bhai.
you tell your idea of how to go about it, and if you have any other alternative also, please suggest.
See, I'm into a private practice right now, Jignesh bhai. I'm not doing mass work or that, so I may not be able to answer that question so well. Only thing I feel means in my clinic we dilate all patients, and recently we have got Optos ultra wide field camera which can capture even through 1 millimeter pupil almost up to equator, So dilatation is not must for that. But creating awareness and making more and more people know that they have diabetes and they should come for eye checkup, creating awareness amongst nephrologists, physician and chemists also, I think would be important to get more patients for screening. If we get more patients coming to us for screening, then how to screen becomes a second problem. But I think the first block is that people don't know they have diabetes, and if they have diabetes, they don't know that they need to check eyes.
Yeah.
So that is the biggest hurdle we have.
Yeah, awareness is already going on. Last 3 months we have been doing it, and all digital testing also, and everybody is have it in their clinic, and we are also contacting the physicians, local physicians, to see that they send the patient the moment it is detected as diabetic.
Correct.
Yes, sir.
Sir. Yeah. Mohan.
Yeah, I lost the connection. Sorry. In Tamil Nadu, we have about 3 or 4 ways of doing this. The first way, what we are doing is, in all the most of the ophthalmology clinics, we have the fundus camera. Okay, so that all the diabetics are being screened. Either a fundus photo is being taken after dilatation, and that is one thing. Second thing is, we have also installed in as many diabetologists clinics porous cameras and remedio cameras, especially in Chennai and other major cities. We have done this. And also we are spreading this to the other cities also. And all the diabetologists who see a minimum of about 50 to 100 patients a day, we have a tie-up, and we have kept what is called a forus or a remedio camera with them, and which is being read by one of the technicians, and the images are being transmitted to the one of the ophthalmologists. The base hospital is connected to that particular diabetologist, and they will know which are the patients to be referred, which are the patients to be followed by the diabetologist. That is number 2. Number 3 is, through the Rotary, we have started a program last year, which is, I'm sure all of you must have heard about it, which is called the Orange Project, which is the Rotary District 3230 erstwhile, now it's 3232 project, which envisages about 600 vision centers across Tamil Nadu, and already we have got about 100 vision centers in and around Chennai in the radius of about 50 to 100 kilometers. And each of these vision centers will have a slit lamp and a Remedio fundus camera and a trained technician to take the photographs and send it again online to the hospital, which has got the tie-up with the vision centers. For example, we have some vision centers. Like Shankar Netra has got some vision centers. Aravinda has got some vision centers. MNI Hospital has got some vision centers. I'm just giving an example of how these vision centers are working. So they are a tie-up with the vision centers. It's not only for the diabetic retinopathy, but also for glaucoma and even spectacle refraction or any basic method. This thing, the primary health care or the eye care is given in the vision centers. The third one is, of course, the physicians themselves. We are through the IMA. What we are doing is the physicians themselves who don't have access to any of these cameras. If they are not able to refer it to the ophthalmologist, we tell them to do a direct ophthalmoscopy, because a direct ophthalmoscopy to find out whether they are having the any maculopathy is aware. This can be done even in an undilated pupil. So you don't have to dilate the pupil to find out whether you have any maculopathy or not. You can see the disc, you can see the macula. If there is any exudates or anything, the patients are referred to the ophthalmologist or to the nearest vision center, and they are dilated there and taken a fundus photograph and then send it across to the thing. So these are the various methods by which we are doing this. What the Aravind is doing is, they've been doing it for quite some time, and they have got the vision centers. That is not part of the Rotary. They have their own vision centers, which they have been running for the past 20-25 years. In all the smaller villages, they are doing. These vision centers are all equipped with slit lamps, and they are all manned by girls, lady who has passed only 10th or 11th standard. They're trained to take the photographs of the fundus after dilatation with a 90 diopter or a 78 diopter. So they're trained to take the photographs and send the photographs by the computer or online to the base hospital in turn to find out whether this thing. Again, we are also using offline, like what Dr. Natarajan is doing, the offline screening using the AI is also being used for this screening, so that you don't have to have the the internet facility at all. So even the AI-based screening is also being done. So what I'm going to do as a president of the TNOA, I'm just trying to get a date from the Chief Minister of Tamil Nadu, wherein all the diabetics, there are approximately 7 to 8 million diabetics in Tamil Nadu, because the total population of Tamil Nadu is about 70 to 75 million, and 7 to 8 million people are diabetics, and we are going to screen the majority of these diabetics. That is the aim of this project, what we are going to start. And across Tamil Nadu, with the help of the Remedio cameras, with the help of the 90 diopter, with the help of the Orange Vision centers, a combination of everything, we are going to do this screening and make it blind-free Tamil Nadu. That is the aim of my the project in Tamil Nadu, TNOA.
Fantastic.
Yes.
Very nice. Yeah. The way we have done the network is fantastic, and the idea that you are going to do it is very good. This is the alternative way that you have suggested. We'll also try and see what best we can do at our level.
Yeah, of course. After listening to Anuj, I'm going to do this also. Listening to Anuj today, I am doing this also. I'm going to planning to start this way of documenting the fundus. So it's really a fantastic way.
I think this will work the best, because it can be done by anybody. Only thing, a little learning is there. Just to hold this camera, so video, anybody can put it on and off. Only once you have that focusing, rest is okay. 30-second video or 10 seconds video is sufficient. Out of that, you take flash photographs and send it. It doesn't look to be difficult, because I also tried the moment I saw that, and that is why.
No, that is because I'll tell you why. Because you are well trained in indirect ophthalmoscopy, Jignesh. Please understand.
Yeah, that is right.
See, when you come to an institute like Shankar Netralaya, Please understand, you
It
are
becomes the second habit.
absolutely.
That's
So
true.
that is the first thing you learn in indirect ophthalmoscopy in Checkup. Wetzel also knows, Santosh
Yes.
also knows, everybody knows
Yeah.
about whoever is Shankar alumni, they all know about it. But I'm just telling you, but all other institutes, for example, I don't want to mention the name because it's a webinar. I don't want to mention the name of the institutes. There are many institutes, medical colleges, wherein indirect ophthalmoscope is not, when I go as an examiner, okay, I ask one of the PGs to do an indirect ophthalmoscopy. She says, I have not seen an indirect ophthalmoscopy
Oh my God.
in my medical college. I have not seen. That is atrocious. What do you do then? I said, we do only slit lamp, 90 diopter. That's all. I have not seen an indirect ophthalmoscopy. Then how do you see the periphery? We have not seen the periphery at all.
Oh my goodness.
Yes. So that is the state of affairs.
I know.
So what we are seeing is probably the tip of the iceberg here. Yeah.
Correct.
Yeah. So
But we'll try and do something about it. We need to train people and the optometrists for this if you have to go a long way, because having cameras, costly cameras and funding is a big no-no in Maharashtra, frankly, I'll tell you. I've been putting forward everywhere. Okay, we require funds for having at least on rental to pick up so many cameras and distribute all over Maharashtra and see to it. And that is why I said at least we go one step this side and let's try this also. Hopefully
Yeah.
it should work. So over to you, Santosh. How do you go about it in Aurangabad? You tell me now, because he's also a VR surgeon, a past alumni of Shankar Netralay,
Yeah.
and he's also doing it in a little different way. Let's hear from you, Santosh.
Yeah. Last month only I come across many vitreous hemorrhage cases, sudden loss of vision, not only in lay people but also in one of I think doctor has come with vitreous hemorrhage. Then I felt that screening is very much required, whether the patient is getting vision loss or not, diminution of vision or not. So screening, apart from screening, I think awareness is very important. So I want to ask Dr. Vatsal Parikh and Dr. Anuj and Dr. Mohan Rajan also,
Yes.
how we can increase the awareness in illiterate as well as literate people.
In the most
Mostly rural
periphery
population.
of the districts, correct?
Yeah. How can
It's
we
a,
increase awareness? What
a
are your
difficult-
ways of thinking? Take on that.
it's a difficult way. What I do is people who have lost eye due to diabetic retinopathy, I think they are the best ambassador to pass on the message, and they can put it seriously and sincerely to all their colleagues and probably create awareness because they've suffered what it is due to.
Yeah.
Because otherwise, till you suffer, you don't feel. It's like, ki hota hai, chalta hai. There's all hearsay, kuch hota nahi hai. And at the same time, there are so many doctors who tell that sugar of 250 or 300 is also good for them, These are the doctors who tell patients. Now, what are you going to tell patients, And I just tell you, about 25 years back, I had a patient with vitreous hemorrhage, diabetic retinopathy and vitreous hemorrhage, and patient himself was diabetologist and not shown his eyes.
Yeah.
That was a state of affairs, about
Absolutely.
25 years back.
Yes, sir.
Good.
I think
In Tamil Nadu, how do you go about it?
No,
Mohan?
we have again a couple of methods. The first method is to we have CME programs through the IMA and to just to what you call sensitize the physicians and the diabetologists that diabetic retinopathy can be there, and please refer these patients as soon as you diagnose diabetes, because we do not know how long they'll be having diabetes before they come to the physician. So that's one thing. The second thing is what we are doing is as part of the Rajan Eye Care and the Chennai Vision Charitable Trust of the community ophthalmology wing of our hospital, is that we have a special van called the Netra Vahana. Okay, the Netra Vahana we started way back in 2010, which is a tele-ophthalmology van. This van contains everything. It's got a fundus camera, fluorescent angiogram, the green laser, the YAG laser, opticals, pharmacy. It's supported by the Cognizant Foundation and Vijay Matraj Foundation of the USA. So this van goes to all the. You're able to hear me?
yes.
Yeah.
Okay. This van goes to all the the villages, about 150 kilometer radius it covers in and around Chennai. It covers about 6 or 7 districts in Tamil Nadu and 2 districts because Andhra is also very close to us. So we cover about 2 districts in Andhra also. So this van is when you go and screen the patients.
Your connection, your voice is breaking. On.
Yeah.
We can hear very well.
I think
we can hear.
You're able to hear me?
What will?
Yes, Mohan, we are able to hear you. Myself
Okay.
and Santosh are able to hear you.
Also, I can hear you very well.
No problem. This van, when it goes to the periphery, when it goes to the villages, so we not only screen the patients for the cataract and other problems, all the patients, especially above the age of 40, what we do is we always check the CBG, that is the blood sugar, and the BP for the patients. Okay? And once we find that the blood sugar is more than 200 or something like that, we dilate the patients and take a photograph of the retina. So then we also have a TV in the van, and this van will have awareness programs in the local language. For example, Tamil, the local language, it will have awareness programs on various eye problems, especially diabetic retinopathy and glaucoma. These are the main 2 blinding diseases which we see in the rural areas. Okay, glaucoma and diabetic retinopathy, because till late stages you can be absolutely normal and the patient may not know anything about it. Okay, so that is the reason why we sensitize the patients, create an awareness in the local language, and tell them, give them pamphlets about this, and identify the patients for diabetic patients and patients who are diabetic retinopathy. We do the laser diagnosis in the van, or bring the patients for advanced diabetic retinopathy. We bring the patients to the base hospital for surgery. So this is another way of doing it. And of course, I'm also starting as part of, I forgot to mention, as part of the TNOA, what we are going to do is we are also going to, like what the Singapore system has started. The Singapore has started a system long time back. This happened about 5-6 years back, or even more than that, wherein every optical shop across Singapore is equipped with a fundus camera.
Wow.
Right? Every optical shop. Because many patients go to the optical shop and so they are found out with the diabetics, the photographs are taken, and the photographs are sent to the main hospital, either SNEC or some other hospital, they are sending it. So similar to that, I'm also going to start a program here wherein every optical shop in Tamil Nadu, as much as possible, will try, because the Rotary is funding, the Rotary matching grants are coming into this for this Orange project. So the Rotary International is funding this project of Orange project. So yeah, so that way I think the funds is not a very major issue, but still when we want to have 600 or 1,000 vision centers, okay, it's going to have a huge amount of what do you call it? Equity is required. That's it.
Absolutely.
The investment is required.
But fantastic suggestions from you, Mohan. As you are always, you are so dynamic and community oriented. That is the best part. Now that the Netra Vahana that you have told me, it's a fantastic idea where you don't have to call the patient to your tertiary center, and we can do it at the primary level. So great. Anuj, do you have any suggestions? Is Anuj there? I think.
Yes, sir. Yes, sir. So
Yeah, anything that is in your mind, the way you have come with this idea, novel idea.
Sharing these videos only of bleeding is that's what I do with the patients. And when we record these video, we relay this live on our screen, which is a 40-inch screen. So patients also, they feel that there is something. And so it's because of this video, so that dynamics of the hemorrhage. So I think it creates a little bit more, whether it's a right thing to scare the patient or not is the other thing, but it is to see the blood is little scary, I feel.
Right. My idea, now I would like to share my ideas the way we do it here. I have a lot of things coming up in my mind regarding awareness. First is all the digital media and the social media should be flooded by all our ophthalmologists with the awareness. Small this thing post which I am going to create. I have already done it once. Now we're going to follow it up because it needs constant bombarding to the public at large. Then we are going to have the on the FM also. I have started the what we call as Drushtikon. It's in Marathi, of course. दृष्टिकोन आपल्या नेत्र आरोग्यासाठी. It's a series of Akashvani programs where we have now started with COVID and subsequently we are going to do for diabetes, glaucoma, and each of this. Again, on TV, we are going to have a public awareness program specifically for diabetic retinopathy with COVID in mind. The COVID, where we have the diabetics which were subclinical have become overtly diabetics. So more so that we have to push this program of public awareness in a big way. So each and every MR who's coming, the medical reps, I am telling that as you have multiple divisions, we have the ophthalmic, you have the physician division also. So I have told them to make stand and request them to tell the physician also that any case that the way you said, you don't know when he is diabetic. The moment he comes and he gets detected, it must be already 4 to 5 years down the line. So the first thing they have to do is a diabetic retinopathy checkup. Either they send it to the person closest to VR or the ophthalmologist, but it has to be done on a priority basis. Today only I spoke to the zonal manager of one of the companies. He is going to do it pan India. He said, not forget pan Maharashtra, we are going to do it pan India. Where they will be locating standees in the waiting rooms of the physician. So the learned patients are going to read with the pictures of diabetic retinopathy in each and every physician's chamber, and of course in his waiting room. It will be displayed. So this is in a big way we are trying to go. Let's see how it works out. I think we are now had a very nice discussion. Any go-home messages by each of the star faculty? Mohan, we start with you first.
I think the basic thing is, Jagnesh, I think you summed it up all. The most important thing is to create awareness.
Correct.
The awareness among the patients, the awareness among the physicians, the diabetologists, the awareness among the fellow ophthalmologists,
Correct.
and awareness in the social media, awareness in the mass media. So all the aspects, we need to bombard from all the fronts as far as awareness is created. See, once you create an awareness, automatically the patients will start coming early to you.
Correct.
Okay.
To the ophthalmologist straight
To
away.
the ophthalmologist, not only to you, to anybody for that matter. So once you tell them, for example, we did a study about 5 years, or say 2016, we found out that only 20% of the Chennai population, only 20% of the Chennai population were aware of a condition that diabetes can affect the eye, that is called diabetic retinopathy. Only 20% in an urban city like Chennai.
Oh my goodness.
Well-educated city, I'm telling you.
Correct.
Highly literate population.
Absolutely.
20%. You will be shocked to hear this. So there is a huge gap there. There is a huge 80% gap there. Okay? This
That
has
is
to be
what we need to
completely
tap.
reversed. Yes. So that is the reason why this problem is occurring. Same thing. Many patients come to you thinking it's cataract, but it is glaucoma, advanced glaucoma, they would have come. So again, same thing. You use the diabetic retinopathy platform to create awareness on glaucoma also. Please don't underestimate. Glaucoma is also increasing in number. So that is another problem we are facing. So both. Yeah.
Fantastic. Good inputs from you, Mohan. As always, whenever you are there on the platform, it's absolutely lively and very interactive. Let's have a view of Dr. Vatsal Bhai also. Each of the panelists, just a go-home message before we sign off. 2 minutes. Vatsal Bhai?
It may look little bad, but I wish diabetic can be like COVID, where patients go blind suddenly, then all will be panicked and be aware of the problem, you know. Because without
sudden awareness.
Sudden awareness.
Anyway, thanks a lot, Vatsal Bhai. Anuj, from you, and then our main moderator, Dr. Santosh, before we sign off.
Yes, sir. I would also say same thing like Vatsal sir, that same strategy as COVID, because if you bombard, because people know about COVID in and out, maybe more than you and me, and all the strains and everything. So same thing, social media
and WhatsApp is the key for awareness.
Thanks a lot. Santosh Bhai,
Yes, yes.
your remarks
Uh,
before, then I do a concluding remarks and thanksgiving by Rajesh. Yeah.
Diabetes alarming, increasing, and we have to make the people, physicians, co-ophthalmologists, all aware of this problem and also of diabetic retinopathy and blindness incidents. And also we have to take help of NGOs, and lot of funds are also required to carry out these screening projects in a very strategic and a categorical way. And pan India, it is very much required nowadays. It is the need of the hour. That is my message.
And thank you very much, Rajesh Bhai. He is our honorary secretary. He is always there, ready to help. He has got innovative ideas himself. And then I'll conclude the session. Rajesh?
No, I think most of the things have already been told.
Very well covered. Yes.
Yeah.
The subspecialty and the super specialists have really covered the topic well. It was an exhaustive discussion. I am sure the most of the periphery of the ophthalmology and the general ophthalmology all over Maharashtra will take a clue from this today's webinar and start working on trying to screen the patients. Even if there is a learning curve, start doing it. That is what is our go-home message today. With the dream of Dr. Natarajan to have it pan-India, diabetic-free India, mainly diabetic retinopathy-free India is what his goal is and his dream is. He's already started it. It was his brainchild to have this committee and also start with the awareness. So we did 2 months of diabetic awareness, and now we are up going for screening. So we require help of each and every ophthalmologist all over Maharashtra. And the main aim of today's webinar was to instill confidence and to go about it. Dr. Mohan Rajan did say it is a little difficult, but definitely doable by each and every person. Regarding the Remedio cameras and the artificial intelligence, that is the next step we are planning to have. In the meantime, try and see that you create awareness also simultaneously as you start screening the patients. Pan Maharashtra, each and every ophthalmologist in Maharashtra should be involved in this great show that we are taking up, and see to it that Maharashtra is fully covered. Thank you very much. Once more, Dr. Mohan Rajan, be with us as a star faculty. Vatsal Bhai, the last moment I just requested and he was ready to be in. Anuj, of course, for his excellent innovative technique. Santosh Bhai for the last moment presentation of Dr. Natarajan and also moderating the show. And our, of course, Rajesh Bhai. Rajesh Bhai, over to you.
Yeah, that was a wonderful CME on diabetic awareness and screening. Dr. Santosh, in absence of Dr. Natarajan, you presented it nicely. We felt as if Dr. Natarajan was presenting.
Yes.
Thanks a lot for accepting last minute request. Dr. Anuj, wonderful presentation. Hats off to you. You made it so simple that it's a boon to every ophthalmologist. You have solved our problem of buying costly fundus camera for screening of diabetic retinopathy. Yes. That was concern. I hope Taswala sir remembers during first managing committee meeting how to go about it. Thank you, Dr. Mohan Rajan and Dr. Vatsal Parik for sparing your valuable time and highlighting on the screening of diabetic retinopathy. Dr. Mohan Rajan, you are doing a great job in Tamil Nadu. Hopefully, we will be able to replicate that in Maharashtra as well. This will help in screening of diabetic retinopathy across Maharashtra, which is the initiative of our President, Dr. Taswala. I also thank audience for joining and Entor for the technical support. Thank you so much and good night.
Thank you. So nice of you, Dr. Rajesh, as usual. It covers up everything what is by me, and all shortcomings, and then we blame for it. And I sincerely apologize if anybody is left out. And a great show as usual. Mohan with you and Vatsal Bhai, and of course all our star faculties. Thank you very much. Let's have more of it in the future too. Thanks a lot.
Thank you. Thank you. Thanks a lot, Jignesh. And all
here now, I would just request all the audience, one sec, before we sign off, we have Dr. Mohan Rajan, who is to contest the post of Vice President in 2022. So be there. All Maharashtra should fully support him. And we are always there, Mohan, with you.
Thank you very much, Jignesh. Thank you.
And one more thing, the referendum which is there. Please see that every votes. It is just 3,500 is the last count which we have, and the last date is 7th of February, 5 p.m. So I would request each and every ophthalmologist who is in the audience and our star faculty to pass it on to maximum people and see that all these 7 proposals that have been put up, the path breaking is going to change the face of AIOS. So please actively participate and motivate others also, not only in Maharashtra, but pan-India. Thank you very much for joining.
Okay, sir. Thanks a lot, sir.
Thanks a lot. Good night.
Yeah, good night.
Anuj, Vatsal, Jignesh.